Hello, I'm Dr. Gaudio. I'm from Italy. I studied medicine at University Vita Salute San Raffaele in Milan, and I did this study during my Erasmus trainship at University of Surrey. This poster is about the demographic and clinical factor for safer pregnancy in diabetes, and I will describe trends over time in a national primary care cohort. So, preconception care for women with diabetes is important and should be part of standard diabetes care from adolescence onward. This should be aimed at the optimization of glycemic control, medications in view of a pregnancy, and the review of comorbidities. This is important to reduce negative pregnancy outcomes. However, only a minority of women with diabetes plan their pregnancy, and most of them conceive with unfavorable factors. So the aim of this study was to describe the change over time of demographic and clinical characteristics in women with either type 1 or type 2 diabetes in this cohort. The Royal College of General Practitioner Research and Surveillance Centre network is an English sentinel network comprising more than 300 practices around England, accounting for 5 million patients. We did repeated annual cross-section analysis to understand the trends of glycemic control, medication use, and comorbidities in women with either type 1 and type 2 diabetes. I considered unfavorable factors for pregnancy, a poor glycemic control, having an HbA1c more than 8.5%, a BMI more than 30, the presence of microalbuminuria, hypertension, and the prescription of those medications not recommended in the case of pregnancy, such as statins, ACE inhibitors, or ARBs, and the prescription of those medications for the therapy of type 2 diabetes, other than metformin and insulin. So the results of my study were taken from 3,000 women in 2004 to 6,000, more than 6,000 women in 2017. The presence of type 2 diabetes slightly increased from 61% to 65% in 2017. As you can see from these two graphs, the glycemic control got better over time. For instance, the mean HbA1c of women with diabetes, either type 1 and type 2, improved over time, and the proportion of those women with a good glycemic control increase. So an ideal glycemic control for me was less than 6.5%, and this increased from 9% to 19% in women with type 1 diabetes, and from 25% to 35% in those with type 2. Although still the majority of women have a suboptimal control of their glycemic index. And another important information is that the presence of obesity increased among those women with type 1 diabetes from almost 20% to 26%, while it remains stable in those with type 2 diabetes, accounting for 2/3 of the cases, which is still really high. The prescription of those medications for the therapy of diabetes increased for women with type 2 diabetes from 22% to 27%, thanks to the introduction of newer medications. That could be the reason why the glycemic control got better over time. The prescription of ACE inhibitors, ARBs, or statins decreased in both women with type 1 and type 2 diabetes, probably in favor of other safer medications for the treatment of comorbidities. As you can see, the cumulative score of factors considered to be unsafe in the case of pregnancy that I mentioned before and were improved over time, so from 2004 to 2017. Here you can see a bar chart with data from 2011 and 2017. As you can see, still the majority of women with either type 1 and type 2 diabetes have at least one unfavorable factor, accounting for more than 60% for those with type 1 and more than 70% with those with type 2. Well, the conclusion of my study was that despite an overall improvement in glycemic control, the majority of women with diabetes still have an unfavorable factor in the case of pregnancy. So we need an enhanced educational intervention on pregnancy planning for what concerns diabetes, and this should target those negative but still modifiable factors in the case of pregnancy, and this should be both for healthcare professionals and patients with diabetes.